Welcome to The Explainer. Today, we're building a practical guide for pharmacists on managing fibromyalgia. We're going to really focus on the crucial counseling points you need to know, because this is about so much more than just what's in the bottle. It's about having the right conversation at the counter that can truly change a patient's life.
So here's our game plan. First, we'll get a solid handle on what fibromyalgia is and why it's so tricky to diagnose. Then, we'll talk about the most important therapies, and spoiler alert, they don't involve a pill. After that, we'll dive deep into the medications you'll actually be dispensing. And finally, we'll wrap it all up with some key counseling points for special situations and the incredible power of empathy.
Okay, let's get right into it. Before we can even think about counseling our treatment, we have to have a rock-solid grasp of what our patients are actually going through. So, what is fibromyalgia, really?
So the crucial point here is that this is not just about pain. It's a multi-symptom disorder. When a patient walks up to your counter, they're not just hurting. They are battling this deep, profound fatigue, that brain fog they can't shake, and sleep that does absolutely nothing to refresh them. It really impacts every single corner of their life.
And listen, this is not some rare condition. 2 to 4%, that means you are absolutely going to see patients with this diagnosis in your practice probably every single week. So understanding their journey is a core part of what we do.
And this right here, this illustrates the demographic skew perfectly. The vast majority of people diagnosed are women, and symptoms usually pop up somewhere between the ages of 30 and 60. That's really important context to have in the back of your mind when you're taking a medication history or offering advice.
You know, a huge challenge for these patients is that there's no single definitive test for fibromyalgia. It's what we call a diagnosis of exclusion. The clinician has to be a bit of a detective, taking a super careful history and running labs, mainly to make sure it's not something else.
And this is exactly what they're trying to rule out. Things like rheumatoid arthritis or even thyroid issues can look a lot like fibromyalgia at first. And because of this, a patient's journey to finally getting a diagnosis can be incredibly long and frustrating, which, as you can imagine, can really affect their trust in the whole healthcare system.
All right, let's move on. We're getting to the absolute foundation of treatment. And this is an area where your advice can make a massive impact, way before a single prescription is even filled.
Okay, if you remember one thing from our talk today, make it this. The evidence is crystal clear. Medications have, at best, modest effects. The real heavy lifting, the cornerstone of managing fibromyalgia, is done through therapies that don't come in a bottle.
And this is what that looks like in the real world. As a pharmacist, you're perfectly positioned to reinforce all of these strategies. Patient education, that's our bread and butter. For exercise, you can be the one to emphasize starting low and slow, what's called graded exercise, so they don't trigger a flare-up. You could have pamphlets on good sleep hygiene, or even recommend apps for stress management. This advice is just as therapeutic as any pill you dispense.
All right, now for our turf, the medication toolkit. When those non-drug therapies just aren't cutting it, what are the go-to agents? And what are the absolutely essential pearls you need to have ready to go?
This right here is the golden rule. The mantra for treating fibromyalgia is, and always should be, start low, go slow. These patients can be incredibly sensitive to side effects, so a slow, gradual titration is absolutely essential for them to stick with it and find the right dose. Let's start with an oldie but a goodie, the tricyclics. Now, yeah, they're antidepressants, but we use them in a totally different way here, especially for patients whose biggest complaint is that they just can't get refreshing sleep. And look at that dosage, right? We're starting at just 5 or 10 milligrams. It's so important to counsel the patient that this tiny dose isn't for depression. It's specifically for their pain and sleep. Advise them to take it a good hour or two before bed to help cut down on that morning hangover feeling. And of course, give them a heads up about the classic anticholinergic effects like dry mouth and constipation.
Moving on to a more modern class, we have the SNRIs, or serotonin norepinephrine reuptake inhibitors. These are often thought of as a first-line drug therapy, and they're an especially good choice if the patient is also dealing with depression.
Now with duloxetine, managing expectations is everything. The source material is very clear. It gives only a small reduction in pain, and it doesn't really help with fatigue or sleep. We need to be upfront about this. Let the patient know that common side effects like nausea are pretty normal at the beginning, but usually get better with time.
Next up are the gabapentinoids, which includes drugs like pregabalin. These guys work on a different pain pathway altogether, and they're another key option in our toolkit.
See a theme developing here?
Slow titration is absolutely crucial to keep the drowsiness and dizziness to a minimum because those side effects are really common. It's also worth pointing out that those super low starting doses aren't going to be effective for pain. The evidence shows we need to get them up into that 300 to 450 milligrams per day range to see a real benefit.
Now, this number is so important for setting realistic goals with your patient. Pregabalin does offer a real benefit, but it's a modest one. We're talking about a 9% better chance of getting significant pain reduction compared to a placebo. It's not a magic bullet, and our patients need to understand that right from the get-go.
Okay, now for a huge red flag, a critical safety warning. The guidelines are very, very clear. We should avoid using NSAIDs and opioids for fibromyalgia. NSAIDs just don't work any better than a placebo, and they pile on side effects. And opioids? There's no good evidence they work, and they come with the serious risk of actually making the patient's pain sensitivity worse, a condition called opioid-induced hyperalgesia.
All right, let's wrap this up by touching on a few special populations and what might just be the most powerful yet underused tool we have as healthcare providers. So, what do you do if your patient is pregnant or breastfeeding? Well, non-drug therapy is always the first choice. But if medication is absolutely necessary, our options are pretty limited. Acetaminophen is generally considered okay, and low-dose amitriptyline seems to be relatively safe in pregnancy, but you really need to be cautious with most of the other agents.
And this quote, this gets to the absolute heart of counseling. So many of these patients have spent years being told their pain isn't real. Your validation, right there at the pharmacy counter, is therapeutic in itself. Just acknowledging their suffering and explaining that the pain is real, even if the brain is processing it differently, can be incredibly powerful.
So I'll leave you with this question to think about. This really reframes our role, doesn't it? For chronic conditions like fibromyalgia, we're not just dispensers of medicine. We are educators, we are coaches, and we are empathetic counselors. The real challenge and the real opportunity to change lives is figuring out how we integrate that into our daily workflow.